Okay, let's talk about the elephant in the triage room. 31.9%. That is the percentage of all births that now involve an induction of labor. If you're an OB-GYN and your labor board is currently buckling under the weight of endless inductions, look, you aren't imagining things. Your exhaustion is totally validated. But what if I told you we now have definitive data to get your patients to a safe vaginal delivery way faster? Let's dive in.
Consider me your brilliant senior attending who just pulled you aside in the hallway to give you the fast, evidence-based lifeline you desperately need for your next shift. We're breaking down the highly anticipated July 2025 ACOG Clinical Practice Guideline on cervical ripening and pregnancy. We're skipping the fluff, just the high-yield pearls that are literally going to change how you practice medicine tonight.
Because we really have to acknowledge how we got into this bottleneck in the first place. Remember the landmark ARRIVE trial? It was amazing, right? It proved that inducing low-risk nulliparous patients at 39 weeks actually decreases C-section and preeclampsia rates. Fantastic. But the fallout was that elective inductions spiked by 42% almost overnight. Patients are now sitting on L&D for a median of 20 hours. We are totally logjammed, which means mastering the art and science of cervical ripening isn't just a nice-to-have anymore, it's absolutely crucial.
All right, Section 1, inside the 2025 guideline. Let's look at what works and what fails.
This is your new best friend, the brand new ACOG Clinical Practice Guideline, number 9. And why should you care about this specific document? Because a staggering 84% of inductions require cervical ripening. 84%. Getting these protocols right is the absolute core of modern obstetric care.
Let's start with our foundation, the good old Bishop score. Look, let's be real. Every single one of us still secretly calculates this on our fingers at 3 a.m. Dilation, effacement, station, consistency, position. Whether your personal threshold is a 3 or an 8, this is how we figure out who needs ripening before we even think about touching the Pitocin. But the real question is, once they actually need ripening, what is the hands-down best method to use?
Moving to Section 2, the ultimate ripening combo. The data has officially spoken.
So I'm going to pose this to you like a heavyweight medical bout. If we take all the mechanical methods and all the pharmacologic methods, the balloons, the prostaglandins, oral, vaginal, and we throw them all into the ring together, what actually wins? What gets your patient to the finish line the fastest, with the lowest risk?
Boom! We have a reigning champion. And this is backed by a massive 40,000 patient meta-analysis. It's the combination of a Foley balloon inflated to 30 milliliters coupled with vaginal misoprostol at a dose of 25 micrograms. This specific exact combo gives you the absolute highest odds of a vaginal delivery within 24 hours, while also giving you the lowest odds of NICU admission, tachysystole, and operative vaginal delivery. It's the holy grail for getting things moving safely.
Which brings us to Section 3, the Misoprostol showdown. Oral versus vaginal. Now, this is the debate that literally tears L&D units apart. Oral or vaginal miso? Which route actually gets our patients safely to the finish line faster, and which one is going to have your nurses blowing up your pager about fetal heart rate decels?
It all comes down to a trade-off. Vaginal misoprostol is your speed demon. It has a higher 24-hour success rate and requires significantly less early oxytocin, which, let me tell you, your nurses will absolutely love when staffing is tight. On the flip side, oral misoprostol is going to mean a slightly longer time to delivery, but it causes significantly less tachysystole with fetal heart rate changes, so you're trading a little bit of speed for a much smoother strip. The secret sauce here is nailing the dosing. So grab a pen, here are your hard clinical pearls. For vaginal, 25 micrograms every 3 to 6 hours is optimal. If you bump that to 50, yeah, you'll deliver them faster, but your tachysystole risk shoots straight up. For oral, you want 25 micrograms every 2 hours or 50 to 100 micrograms every 4 hours. And here is a massive practice changer for you. Static oral dosing actually beats hourly titrated dosing. Same efficacy, way fewer complications like C-sections or tachysystole. Keep it simple. Oh, and let's just myth bust this right now. Skip the sublingual and buccal routes. Just don't do it. The rapid absorption spikes uterine tachysystole with literally zero benefit to your 24-hour vaginal delivery rate. It is an entirely unnecessary risk.
Section 4. The truth about dinoprostone, aka the expensive fridge jelly.
All right, I am about to drop the mic on dinoprostone.
A huge 2024 meta-analysis just proved that our cheap, room-temperature vaginal misoprostol is exactly as effective at achieving vaginal delivery, but it actually results in fewer maternal adverse outcomes, like infection and hemorrhage, compared to vaginal dinoprostone. Plus, dinoprostone requires refrigeration, it has a higher need for oxytocin augmentation, and it costs a fortune. The expensive fridge jelly does not win this fight, folks. Miso does.
Wrapping up with Section 5. Shift-changing clinical takeaways you can apply tonight.
This is perhaps the most profound stance in the entire new guideline. We have to be practicing trauma-informed care. Offering oral misoprostol to a patient who has a trauma history just to avoid triggering them with repeated vaginal exams isn't just you being a nice doctor. That is formally recognized evidence-based medicine. Prioritize their autonomy, minimize the exams, and remember that emotional safety is absolutely a vital sign.
And here is a final, mind-blowing pearl that might actually help decompress your unit. For low-risk patients, ACOG officially suggests that outpatient cervical ripening is a safe, effective way to reduce that grueling admission to delivery time. You can actually start the process, send them home, and bring them back when they are truly ready for active labor. Just imagine what that does for patient comfort, not to mention your bed management.
To cap this off, I want to give you absolute clinical clarity straight from ACOG's strong recommendations. They state you can use pharmacologic, mechanical, or a combination of both. This completely validates your clinical judgment. You are not boxed into a single rigid protocol. You are fully empowered to look at the patient in front of you, look at your nursing resources, and choose the best, safest tool for the job.
So, doctor, I'm going to leave you with this. Which protocol are you updating on your labor board tonight? Are you finally making the jump to the Foley-Miso combo? Switching from titrated to static oral dosing? Take this data, go out there and be brilliant, and I will catch you in the next explainer.